Hello everyone, I am Dr. Rajesh Badani, practicing as an Associate Director, Department of Cardiology, Aditya Birla Memorial Hospital, Pune. I am practicing over the past 15 years. So my today's topic is MRA, the missing link in heart failure management. As we all know, mineralocorticoid receptor antagonists have been introduced since 1950, where spironolactone first came in as a diuretic. But it almost took 3 decades for this drug to be approved in heart failure with reduced ejection fraction, when the first trial, RAL study, was published in 1999, and that's when spironolactone got approval for the management of HFrEF. The next drug which came in was eplerenone, which the first trial was probably the EPHESIS trial in 2003. And 8 years later, in 2011, there was another trial called EMPHASIS Heart Failure, where eplerenone was used in stable heart failure patients. 2014, there was a reminder study in which again eplerenone was used in patients who were post-MI, and the drug was started immediately on day 1 with an ejection fraction of below 40%. Now we need to understand that why MRAs have got a significant benefit. It's because aldosterone has significant negative influence on the body by salt and water retention, inflammation, fibrosis, as well as a lot of deleterious effect on the ventricular myocardium. At cellular level, when mineralocorticoid receptor antagonism occurs, there is significant remodeling which occurs at cellular level, which results in improvement of your ventricular function, systolic as well as diastolic, which results in improvement in symptoms, quality of life, reduction of hospitalization, and finally helps in mortality benefit and improved survival. MRA definitely decrease a lot of biomarker, particularly the NT-proBNP, which is elevated in patients with HFrEF. Now you need to understand what are the indications that you need to use this drug. We already know that it is to be used in people with ejection fraction below 40%, and you can use it on day 1 of the diagnosis of an MI with EF below or equal to 40. You can use it in the ICU, you can use it in the OPD, as well as you can add on these therapies whenever you diagnose a patient with HFrEF. 2 important factors: monitor serum potassium and creatinine. If your creatinine is above 2.5 or eGFR is below 30, do not use this drug. And when the potassium is at around 5, be very careful. Monitor potassium regularly. If it is 5.5, reduce the dose to 50%, and if it is above 6, stop the drug, re-evaluate the potassium, and then restart the drug in alternate doses. Eplerenone is one of the commonest drug used because of the androgen as well as the progesterone effect. Steroid effects are very less with eplerenone. Spironolactone has almost 10 times incidence of gynecomastia in males. That is the reason this drug is again not very widely used. The latest kid on the block is finerenone, which is probably the latest MRA, and as of now it has received approval for heart failure with mid-range and preserved ejection fraction, whereas as of now we do not have any approval of finerenone being used in patients with HFrEF, which over a period of time newer trials would tell us. So in a nutshell, MRA, why is it important? Because traditionally in all the Indian studies as well as the literature in abroad, only 39 to 40% of the people with HFrEF are receiving eplerenone as well as an MRAs. So I believe that should be the drug that should be added to our armamentarium. It's a fantastic drug, but somehow in India as well as abroad, this drug is used not very frequently, and that is why we call the topic as the missing link. That despite being available since so many years, the usage in clinical practice, because of therapeutic inertia, there is significant reduction of usage. So I think my only concern is that we probably should enhance the usage of MRA in clinical practice because it has got great therapeutic benefits. Thank you very much.